Hi, my name is Anna. I'm a high school student participating in the U of R's Explorations in Pathology pre-college program. I made a poster addressing whether or how artificial intelligence could replace immunohistochemistry for detecting PD-L1 expression in cancer cells as part of my project researching PD-L1. However, since I was, pretty limited in space, I also wanted to create a video on the topic, going more in depth on the development of a PD-L1 AI model and its potential for advancing the entire field of computational pathology. But first off, let me introduce what PD-L1 is. So PD-L1 is short for programmed death ligand 1. It's a transmembrane immune checkpoint protein expressed on a number of self cells in the body. So this includes some of your macrophages, activated T and B cells, dendritic cells, and this protein, PD-L1, it dimerizes or interacts with the PD-1 protein on cytotoxic T cells to prevent the CD8 cell from killing. So, CD8 or cytotoxic T cells are part of the adaptive immune response. And when they're activated by the presence of CD4 or helper T cell interleukins, they kill off the abnormal self cells that they come across, including ones infected by viruses or cancers. So normally, this PD-L1 PD-1 pathway acts as a healthy check on the CD8 cell cytotoxicity, since an overactive immune response, as seen in autoimmune diseases, can be incredibly damaging. However, some cancer cells have learned to exploit this protective mechanism, particularly if they reside in an immune environment rich in CD8 cells and CD4 cytokines. Some are capable of developing PD-L1 expression as an adaptive immune mechanism. So, as you can imagine, this causes some serious issues since the CD8 cells can no longer do their job, and the cancerous cells can now multiply without limitation. And beyond this, researchers have also uncovered that PD-L1 expression contributes to EMT, which is the epithelial to mesenchymal transition of cancer cells. And this promotes cancer proliferation and metastasis, in addition to the development of CSC or cancer stem cell like phenotypes, which means that some cancer cells remain undifferentiated, which allows cancer to reoccur after treatment and resist therapies. So to address the pro-tumorigenic nature of PD-L1 expression, immune checkpoint inhibitors, or ICIs, have been developed over the years. So the treatment involves the infusion of antibodies that attach to the PD-L1 on cancer cells, blocking the PD-L1 PD-1 pathway, protecting them, essentially allowing the immune system to return to clearing out the metaplasia. They're an immunotherapy because they boost the immune system's innate response to abnormalities. Because ICI immunotherapy so specifically targets the PD-L1 PD-1 pathway, it's only effective in treating cancers with high PD-L1 expression, which is why detecting expression is so important. And so PD-L1 expression is quantified with a tumor proportion score, or TPS, and treatment with ICIs is normally prescribed depending on that score. So traditionally, or more so currently, the TPS is determined through immunohistochemistry, or IHC. So a tissue slide is stained with antibodies targeting specific antigens, and in this case, it'd be the PD-L1 surface protein. IHC for PD-L1 detection is done on a tissue sample containing at least 100 viable tumor cells, and one of four FDA-approved PD-L1 clones or antibodies are used to stain the slide, and the TPS is manually calculated by pathologists using the formula of the number of positively staining tumor cells over the total number of viable tumor cells times 100. If you look at this slide, this is what a pathologist would see, and they would have to manually determine how many of the cells seen in this are first tumor cells and how many are stained tumor cells. And as you can imagine, this can be an incredibly tedious process. And I've heard through the grapevine that most, not all, but most pathologists opt to simply visually estimate the staining proportion rather than manually counting. So, like looking at this same slide, like if you were to estimate the TPS, what would you guess? Because according to the official pathologist report, this has a TPS of 80%, which, maybe the section, maybe the part that we're looking at right now is not representative of the entire slide, but I'm not sure if you would have guessed a number that close to 80%. My point kind of is that humans, they're not very good at visual estimation. And even if our pathologists are highly experienced with visual analysis, a decision to visually estimate instead of actually count how many cells there are to determine treatment can be highly detrimental to the well being of the patients. For example, the common TPS threshold levels for immune checkpoint inhibitors are 1%, 5%, 10%, and 50%. But how confident can you really be about being able to correctly determine the difference between 1 and 5%, 5 and 10%? Like if the true TPS is 6%, but a pathologist visually evaluates as 3 or 4%, they could be under treating the patient at a 5% TPS like threshold level. So the current challenge with IHC, namely how inconvenient it is for pathologists to determine values like the TPS, made me wonder whether AI could be used instead, especially with the consistently advancing progress in machine learning algorithms. So when I was first introduced to pathology and histology, both before this program and in explorations in pathology, there was this emphasis on learning what normal histology looked like before trying to determine what was abnormal. Because there really is no set formula for determining what is unhealthy or healthy, rather, like a complex series of factors that can combine to assist you in that decision. So that's why, like, a simple image processing computer algorithm for histology analysis can't really be developed. But it's what I thought that neural networks would be perfect for addressing. So I did some research and found that Tianjin University's Department of Pathology actually published a paper in 2022 about a deep learning model they had developed for PD-L1 expression detection in non-small cell lung carcinoma or NSCLC patients. So the model built off existing image segmentation models, specifically the algorithm used in QPath, which is an open source digital pathology image analysis platform. So the model first segmented the images into like tumorous and regular tissue sections before determining the staining area to calculate the TPS. So if you wanted to see like a larger image, first this is the raw, and then it's segmented into tumorous and non-tumorous. Before the tumor section is separated into positive and negatively stained. So this model was trained on a total of 563 total whole slide images or WSIs, including 173 positive and 390 negative slides. And when it was tested on 110 new slides that it hadn't seen before, it was able to generate a TPS with an impressive 93.26% accuracy, 96.41% specificity, and 92.48% precision when compared to pathologists specially trained in IHC or TPS, which was more consistent than non specially trained but like certified pathologists in their answers. The same study also evaluating using the model as an assistive tool, so providing untrained pathologists with a visualization of the tumor area and positively staining sections, as well as the AI determined TPS as a secondary point of reference, and found that such a decreased the time needed by the untrained pathologists to come up with a TPS substantially. So from this paper, the benefits of using AI for IHC are pretty obvious. It increases the efficiency, consistency, and reproducibility of image analysis substantially. Additionally, if implemented as like an assistive tool for non-IHC trained pathologists, it can increase the accessibility of PD-L1 testing, expanding the number of pathologists who can do it from the select few with substantial training and experience with staining assays to a much larger group. But most of all, implementing AI into IHC can advance the entire field of computational pathology. Computational pathology has already modernized the pathological sciences with like whole slide imaging and digital pathology. But with new AI technology, histology analysis could be substantially accelerated, with AI acting as just a screening tool for pathologists, sorting out benign cases, flagging ones of concern, and allowing pathologists, the human ones, to dedicate more time to analyzing and diagnosing unhealthy patients. So to me, this all seems pretty amazing. However, as promising as AI for PDL and detection and pathology as a whole sounds, there are definitely some concerns to keep in mind. The capabilities of AR are finite, so if given weakly stained images, they may not be able to accurately calculate the TPS. And since these models are trained on human selected data, algorithmic bias is also a point of concern. The AI is only capable of pinpointing discrepancies that it has been trained to see. So if the training data it's given is like disproportionately represents certain types of images, then the AI may fail to identify that something is wrong when it is. And those functional limitations of AI come on top of ethical ones. So serious conversations really need to be had on what level of reliance on AI is appropriate. Whether using patient data to train the models is a violation of their privacy. And, if a misdiagnosis is made at the expense of a patient, who's to blame? Is it the doctor or the AI? So, since the use of AI in pathology is still in its infant stages, it's impossible to tell where it will go. But additional research into AI models like this one developed for PD-L1 could replace the more strenuous IHC tasks like coming up with TPS with automation. And the model, even though it's impressive, it's still far from implementation. But with like additional training and more rigorous testing, possibly the open sourcing of its code, I feel like it could definitely develop to the point where it can be implemented on a much larger scale for NSCLC cases and possibly other cancers. However, the expanding role of that artificial intelligence has also brings the concern of whether automation will eventually replace pathologists altogether, since, they can maybe sometimes do our jobs better than we can. But I really feel like AI will only ever act as an invaluable assistive tool for doctors in the next couple of decades because nothing can really replace the value of the direct patient interaction afforded by humans. Instead, I feel like it'll just take a role alongside human doctors in forwarding medicine's process. So I don't think complete job loss should be an area of like real concern. As for PD-L1, the current research landscape is centered around evaluating combination therapies, such as combining ICIs with chemotherapy or radiotherapy, and seeing how effective the treatments work in conjunction. There's also research being done into new possible ICIs. One that I found pretty unique was research into the anti cancer properties of food derived small molecules like capsaicin, the spicy chemical from like peppers, and 6-gingerol, which is derived from ginger root. Through some molecular modeling, researchers found that these food molecules actually dimerize with PD-L1, possibly preventing the protein from interacting with the PD-1 on CD8 cells, analogous to the mechanism of action of current ICIs. That about wraps up what I learned through researching PD-L1 for the Explorations in Pathology program. Here's a slide with the sources I used, or at least some of the sources I used for my research. Thank you so much for watching this video, and special thanks to Dr. Findice Hosi for posting it and all the invaluable help she provided throughout the research process, and also for running the EIP program. Um, Bye. I hope you have a good one.